Dr. Marcus Kettler come give us his presentation.
Thank you very much, Tamara. Thanks to you for not being disappointed in the end. Nevertheless, I think an important point here is that both of us will focus on patients not on dialysis. And I would like to first of all set the stage concerning a bit pathophysiology and epidemiology, and then go through the studies that were discussed during the working group meetings on this issue. Quick step back, Tamara mentioned that already.
That CKD MBD is a term coined a little bit more than 10 years ago. And the important thing here is that from a bone-centric point of view, cardiovascular disease outcomes, heart outcomes were considered here, and the link between the lab parameters, the bone disease, is probably vascular calcification in this regard. And if we go back to the beginning and the pathophysiology we have here, let's say on the left side, the traditional view is that secondary hyperparathyroidism starts off with a shrinking kidney. The kidney is not able to activate 125 vitamin D anymore in a sufficient way. And this leads to an increased release of PTH as well as the consecutive hypocalcemia that may occur. And phosphate was considered as the third player in this game, while high phosphate levels led or contributes to PTH secretion, but nevertheless the vitamin D calcium axis was considered more important. Recent research has put our view into a, let's say, more phosphocentric view. So we learned that one of the earliest changes that occurs in CKD is an increase in FGF23 levels, which is probably intended to keep the phosphate levels at bay as long as possible. But as a direct consequence of FGF23 release and increases, 125 hydroxylation is also blunted, and this then leads to similar procedures as they are considered at the left margin. This, however, puts phosphate into an early context and into the early question whether we should tackle with phosphate levels at a very early stage. The exact mechanisms are not exactly known. So what we know is that if we absorb phosphorus into the body, by some means the osteocyte of the bone is messaged to release FGF23 in the circulation. And one of the major actions of FGF23 is to inhibit sodium phosphate cotransporters in the kidney, which leads to a decrease in phosphate reabsorption and to phosphaturia. And this mechanism is considered very powerful because, as you can see here, even in stage 4 or stage 5 patients who have a good residual diuresis, up to 500 milligrams of phosphate can still be excreted. And this, of course, is a matter of prevention from hyperphosphatemia through a long journey in chronic kidney disease. Brian Kestenbaum was one of the people instrumental in looking at phosphate levels in CKD patients not on dialysis. And this analysis of about 3,000 patients shows that hyperphosphatemia is really occurring quite late in kidney disease. So usually the GFR has to drop to 30 or 25 in order to have a few patients develop overt hyperphosphatemia. So it's, the body is indeed protected from this development over quite a long period of time. Nevertheless, and this is from the same study, those patients with the highest phosphate levels here have the highest risk of mortality. And even in this highest quintile, there are patients who still have high normal phosphate levels, so not elevated above the normal range. So a message that is sent and that also may be of clinical importance considering when to treat.
Orlando Gutierrez was among the first who reported on FGF23 levels in CKD patients not on dialysis. And you can see here that with declining renal function, FGF23 levels start to rise quite significantly. And this looks like a flat curve, but I would like to point out that the FGF23 that is shown here, that this is a logarithmic scale, so it's quite a steep scale actually. And in the same patients, he showed that the fractional, so the relative phosphate excretion, is quite significantly increasing throughout the course of loss of renal function. So coming from an average of about 20% going up to values like 60, 70%. And this is probably one of the key reasons why CKD patients not on dialysis are protected from overt hyperphosphatemia for such a long time. This is how FGF23 in real life develops, and this is work from Miles Wolf and Tamara's groups, which I find is very instructive because it shows the magnitudes of what is happening here on a regulatory scale. So usually, and most of us in the room should have FGF23 levels around 30 to 50 units per ml. And there are individuals with normal kidney function who may develop FGF23 levels which are quite high, mostly due to a decreased degradation of the FGF23, like in X-linked hypophosphatemic rickets in young children who develop a hypophosphatemic kind of bone disease that is quite severe and very comparable to the severe rickets with vitamin D deficiency. There are a few individuals that are born with a loss of function or with a with a FGF23 deficiency, and they are severely hyperphosphatemic. I have a 14-year-old boy in my outpatient clinic who has a phosphate on average of 3 millimoles per liter and who has calcifications around his joints, elbows, hips, for example, and who needs to be treated quite significantly with doses of phosphate binders. And what you can see here is that FGF23 levels rise as early as in CKD stage 2, 3, 4, and then on dialysis where hyperphosphatemia gets outregulated, they may go up to levels like 50,000, 100,000 units. What is important maybe to consider, of course, is that these early rises have, first of all, an adaptive and a function. So they prevent us from hyperphosphatemia, the CKD patients, and probably also from calcification progression. What we know from animal models, for example, that try to block FGF23 in these early stages of CKD. And what we don't know is where is the cutoff level, where is the threshold that distinguishes from adaptation to maladaptation. And this is something we have to learn in the near future. What we know, again, from Dr. Isakova's work is that in CKD patients not on dialysis, a cohort here of about 3,000 patients, that FGF23 levels indicate a high mortality risk. And that a cutoff here that is associated with an increased risk may already be reached with levels of 70 to 100 to 150 units per ml. So a very interesting relationship, maybe due to the phosphate, but maybe due to FGF23 alone. And this was also a paper that shows the question whether FGF23 may cause collateral damage as a regulatory hormone on its own. And I think many of you are aware that left ventricular hypertrophy may be very well and pathophysiologically related to these increases of FGF23 levels. So the current concept is probably that the sequence of events in CKD MBD starts with elevations in FGF23 in order to keep the phosphate controlled. This is directly followed by decreases in calcitriol hydroxylation, and this parallels or starts the development of secondary hyperparathyroidism. At some point, these compensatory mechanisms are not sufficient anymore to keep the phosphate normal, and this all exacerbates on dialysis. And after successful transplantation, these systems have all a potency to normalize again, usually in this early phase after transplantation, with this drop in phosphate, which is due to the presence of two high phosphaturic hormones, which are FGF23 and PTH. The question now is, when should we treat? Should we treat when hyperphosphatemia gets visible? Should we perhaps treat much earlier, where potentially starting a phosphate balance that starts to get positive leads to these compensatory mechanisms? Or should we keep it like very conservatively to start hyperphosphatemia when patients enter dialysis? And I would like now to go through a few studies with you that have been published since the KDIGO guidelines in 2009 and were kind of instrumental for the update that we were working on. This was still at the end of the decision-making process for the 2009 guidelines by Russo et al., the first study that was performed on vascular calcification in CKD patients not on dialysis, and these were CKD patients who were hyperphosphatemic. One group was just put on a low phosphate diet. One group was put on a low phosphate diet with the binder calcium carbonate. One group was put on a phosphate diet with the binder sevelamer. Small groups, 30 patients in each group, so not a large study, more a pilot study. But the result here showed that with the calcium-free binder sevelamer, there was there was only very little progression over 1 year of observation. Calcium carbonate and controls were not significantly different against each other, but there was also not an increased calcification with the calcium-containing binder. And if you compare the annualized calcification score progression, you can see quite a significant difference here between sevelamer and the two other groups. The same group then went into a bit of a larger trial with randomizing a total of 239 patients who were either allocated to sevelamer or to calcium carbonate treatment. And in this study, the follow-up was 3 years. And two of the more remarkable endpoints was that after a delay period of about 1 year, the mortality or the survival was improved in the sevelamer treated group versus the calcium carbonate group. And interestingly, also the inception to dialysis, so the progression of chronic kidney disease was reduced with the sevelamer treatment. These patients, again, CKD patients not on dialysis with hyperphosphatemia. A study that I also had the pleasure and honor to participate in was a pilot trial where Geoff Block, as a leader and a group of people, asked themselves whether we should treat even earlier, whether we should treat patients in CKD who have phosphate levels in the high normal range. These patients were all in CKD stage 3B or 4, so the GFR was below 45 mils per minute. And as the idea was that phosphate binding, these three groups, lanthanum, sevelamer, and calcium acetate, were looked at together as a kind of an active group, and they had a matched placebo group here. Observation period was relatively short, 9 months. The idea was, in case of positive results, to go from there in a large prospective randomized controlled trial that looks at hard endpoints. What we found was that it was possible, however, with relatively high doses of the phosphate binders, to lower the serum phosphate, and the original aim to lower it below the median of the normal range was only achieved in relatively few patients. Urinary phosphate excretion dropped by 22%, and something that maybe was not unexpected was that in the placebo group there was a slight progression of hyperparathyroidism, which was halted with the phosphate binder treatment. FGF23 levels, for example, however, did not change. And one thing that was a bit particular about this trial was that there were many patients who did not have excessively FGF23 elevations at this time. And the big and completely unexpected surprise was that coronary artery calcification change and progression was not observed in the placebo arm, but observed in the treatment arm. So that was, of course, the opposite of what we expected in this group. The same was true for the aortic calcification. So a very surprising result. We then looked at the then small groups of subgroups of phosphate binders, and we had to realize that this went mostly on the account of the calcium acetate. But what could be said as well was that there was no significant difference between placebo and the two calcium-free binders. So no big advantage in these patients who were CKD patients not on dialysis, but mostly without hyperphosphatemia. And this study got a second push maybe 1 year later when Sharon Moe's group and Kathleen Hill published a metabolic study on phosphate and calcium handling in the same kind of group of patients. So they were all also in CKD stages 3B and 4. Very small group, I think it was 8 or 9 patients. They were housed on a metabolic ward for quite a bit of time. And the design was that these patients received a fixed diet of 1 gram of calcium per day plus 1.5 grams of phosphate per day. And one experimental stage was they were given placebo tablets to the meals or 500 milligrams calcium carbonate per meal. And they were compared to each other in a crossover fashion, which of course is an interesting tool to get some good statistical relevance of the results. And the results in a way were also surprising, because even in this more or less advanced stage of CKD, patients were not in an overtly positive phosphate balance, and actually the binder calcium carbonate did not change the phosphate balance at all. The second surprise also was that the patients were not in a negative calcium balance, because at least I learned when I was trained that due to the calcitriol deficiency, there is a stage where patients are in negative calcium balance, should be put out of that. That was not the case for this group of patients, but what was observed was, at least in such a short-term experiment, there was developed after like 2 weeks a quite positive calcium balance. And this, in a way, fit to the data that were shown and investigated in the previous early introduced trial by Geoff Block and co-workers. So what about guidelines in patients not on dialysis? I will only talk about briefly 2 of them, because many of the others are more general or also fixed on the dialysis stage. But what is a bit new now is to say that it is to base phosphate lowering treatment on progressively and persistently elevated serum phosphorus, in contrast to what we said before, that in CKD patients not on dialysis, phosphate levels should be maintained in the normal range. So the focus is now on the development of hyperphosphatemia. The rationale: in 2009, the guideline commented that available phosphate binders are all effective in the treatment of hyperphosphatemia, and that there is evidence that calcium-free binders may favor halting progression of vascular calcification versus calcium-containing binders, for example, in not on dialysis patients, the Russo trial. But now concerns about calcium balance, uncertainties about phosphate lowering in CKD patients not on dialysis, additional hard endpoint trials, and a systematic review, which I didn't mention here, due to the policy of the evidence review team that we had in the process, prompted in the decision to re-evaluate this recommendation. This decision was made in Madrid in 2013. And it was especially this very early phosphate lowering trial that showed that phosphate could be lowered, that this, however, did not impact on FGF23, and that with the calcium-containing binder even had a negative progression impact on coronary calcification. So this block study studied subjects with essentially normal phosphorus, and as such, normal phosphatemia may not be an indication to start phosphate-lowering treatments. And this suggests that early preventive treatment of hyperphosphatemia is not supported by data. The work group felt that the updated guidelines should clarify that phosphate-lowering therapies may thus only be indicated in the case of progressive or persistent hyperphosphatemia. The next guideline now, and as the previous one, suggests that in all stages of CKD, those patients who receive phosphate-lowering treatment, the restriction of the dose of calcium-based phosphate binders is given. This is the same as it was available in the 2009 guidelines, but this guideline had a qualifier that restricted this recommendation to patients with hypercalcemia, to patients with presence of calcification, or with low bone turnover. But these trials now from the OREO, for example, or also the risk warning by block study, was not restricted to such patients with these pre-existing risks, and so these qualifiers were deleted. In children, the situation is a bit different because of the growing bone in some phases, but still they also have some calcification risk, but this had to be added at this guideline. So as a rationale, new evidence from 3 RCTs supports a more general recommendation to restrict calcium-based phosphate binders in hyperphosphatemic patients of all stages of CKD. One may ask why not avoid, but this, of course, has 2 reasons. Reason number 1 is that phosphate binding, even with calcium binders, is probably better than no phosphate binding, and some areas of the world do not have the full portfolio available. And so this was one of the major reasons for this reasoning. And again, I show you the calcium acetate as a progression factor for calcification in the block study. And also in hyperphosphatemic pre-dialysis patients, the positive effect of the calcium-free binder in this regard. So I come to my summary, which is that hyperphosphatemia is one of the most powerful mortality and calcification risk factors in all stages of CKD. In CKD patients not on dialysis, the optimal time point and mode to start phosphate-lowering therapies remains to be defined. A preventive treatment mode in normal phosphatemic patients is currently not justified by study data. And in hyperphosphatemic CKD patients not on dialysis, treatment with calcium-free phosphate binders is associated with improved survival and slower progression to ESRD than treatment with calcium-containing compounds, at least when there is a high dose of such compounds. And as such, inappropriate calcium loading should be avoided in all CKD stages. And I thank you very much for your kind attention.